Good morning, everybody, and thank you for attending OSS's first workman's compensation webinar. We're happy to have you all join us via Zoom today, and we hope that this goes very smoothly for everybody because I think we have a really good talk for you. My name is Suzette Song. I'm a longtime partner here at OSS Health. I think I know a bunch of you on the call, so welcome, and welcome also to the folks that I haven't met yet. I'm the Vice President of Medical Affairs here at OSS, and I'm super happy to have you here. Today, we're going to have Dr. Michael Falci, who's going to discuss foot and ankle injuries in the workplace. I think you're going to get a lot of information, and I think you'll find the information and the pictures pretty interesting. Dr. Falci is a podiatric surgeon who focuses his practice on foot and ankle pathology. He offers both surgical and non-surgical treatment options for his patients. His interests include sports medicine, primary repair of tendons, alleviating bunion and great toe pain, fracture management and recovery, minimally invasive foot ankle procedures, advanced diabetic wound care. As you can see, he's pretty busy because there's a lot of stuff going on in our feet and our ankles, as I think all of you guys know. And as a foot and ankle specialist, he sure sees a lot of injuries that occur at work. So I think he's perfect to be talking to us today. Before I begin, I have to read this disclosure. If we could, thank you. All individuals who are in a position to control the content of this educational activity are required to disclose all relevant financial relationships in any amount occurring within the past 12 months, related both content and commercial supporters of the activity. The planning committee and presenters do not have any relevant financial relationship with any of the commercial interests. Thank you. Now I would like to introduce Dr. Michael Falci, and I'm gonna let you take it away. Oh, I'm sorry, I should do some housekeeping first, my bad. So if you can see there's a Q&A button. If you have any questions, go ahead and throw them in there. We're going to leave time at the end and try to get to all of them. If you have any audio visual problems or have any questions, you can throw those into the chat box if you want to send them directly to me. That way they're not distracting to the audience. That would be great. But put your questions in the Q&A and put your other stuff in the chat. Okay. Now I think we can start. Dr. Falci.
Thank you, Dr. Song. Appreciate it. So again, my name is Dr. Michael Falci, DPM. I'm one of the podiatric surgeons here at OSS from the York, Pennsylvania area. Grew up here, went to Temple University in Philadelphia, and then I continued my postgraduate training there in Philadelphia at Temple University School of Podiatric Medicine, the Foot and Ankle Institute. Then I completed my 3-year surgical residency at Reading Hospital, which is now, I believe, Tower Health, a level 1 trauma center in Reading, Pennsylvania. I've been at OSS for approximately 3 years now. And we'll get right into what we're going to be going over today. Thank you all for joining us. So to begin, just why we're kind of talking about everything today, the workers' comp injuries, the incidents that they occur in, estimated as there's about 12 million work-related injuries yearly, which is a large amount, obviously. And that's 20% of all injuries sustained in the United States. So a pretty large portion. And over 7 million of them are occur in the musculoskeletal system. Foot and ankle injuries, approximately 10% of all of the injuries. The average age is between 25 and 30. Males are injured more frequently than females. And as you expect, and you know, the jobs are the service jobs, manufacturing, retail, construction, everything that you are going to be doing more physical labor and just the more strenuous job activities. Construction and industry, that's probably what most people think of when they think of any injury in general. And that's going to be 83% of those foot and ankle injuries. It's going to be, again, a predominantly large population of males, again, in your mid 30s, That's probably that age where we still think we're all invincible and indestructible, and more frequently in the summer. Again, just some more information regarding some of the injuries. Return of work, 20% less for each 10-year increase in age. So as we get older in each decade of life, obviously the rate of return is going to be lower. We're not healing as well as we should. Our bones are not as strong. That osteopenia, osteoporosis is kicking in, and it's just a slower rate of return as we could expect. So the etiology of foot and ankle injuries that we see, the sprains, the strains, contusions, lacerations, fractures. The sprains and strains, that's the majority of it. That's your 42%. So almost half are the sprains and strains of the foot and the ankle. And, you know, that's kind of what most people think of when they think of, you know, foot and ankle injury immediately is rolling your ankle. So throughout the presentation, you'll see some of these blue slides. If you see a blue slide with the little heart there, because I've used these for my own patients, these are the ones that I've used or that are my own cases. The majority of these ones with the blue outlines on them. So you'll see some of our, you know, my workman's comp cases and some of the pre and post ops and whatnot. So getting into the ankle sprains and strains, 70%, fractures 15, contusions. We do see a lot of these obviously in the workplace, in the ankle, and then in the foot itself. Again, the contusions, fractures. Contusions are the highest just because it's bumping your ankle against something. It's you know, hitting your ankle or your foot against the door, or tripping and falling backwards, and you don't suffer a true fracture, fortunately, but we do see a lot of the contusions, bruising, and they still need the appropriate workup. Toes, fractures, that's going to be the majority of the toe injuries because they are the small bones. They are more the brittle bones in the forefoot. So you're going to see more fractures in the toes. You can see right there, that little avulsion fracture that we see often. Fortunately, the lesser toes we don't see as often because a lot of times we have those steel-toed work boots. Most common mechanism of injury, we're going to see contact with an object, falls, harmful force, vehicles, machinery. We'll get into that a little bit. I have a few case presentations on pallet jack injuries. I feel like we've had a run on them recently, unfortunately, but we do see them pretty often. So mechanism of injury, again, the repetitive trauma are very uncommon. That's one thing that we'll talk about today. You might have one of your you know, the patients or the clients that they come with the foot pain, and you have to really distinguish whether it is a stress fracture or it's repetitive or it's acute trauma. A lot of times you'll see here the stress fractures, plantar fasciitis, tendonitis, toenail issues. Sometimes that's chronic issues that the patient thinks that may have been acute, but it's a lingering issue, and we'll kind of show you based on the x-rays, the MRIs, how you can kind of distinguish between those acute and chronic issues that really help us determine whether this is a workman's comp injury or this is a longstanding issue that's just maybe aggravated in the workplace. So impact of the economy, really, the average number of days missed from work is 5, and $600 million is paid yearly in workers' compensation for just the foot and ankle. So that is a large number, as you can tell, for you know, these work-related injuries, which lead to industry obviously bumping up safety precautions and measures. So again, some of the patients that I've had, you can see the little blue areas here, the picture. So this was one that I had a direct blow, phalangeal fractures. Phalanges are the toes, contusions, crush. This one was getting run over by even just a small wheelbarrow. It was a kid. You could see there's open growth plates, and that did require open reduction with internal fixation. You can see just here, I posted on the right, similarly to what you would expect out of these, and restoring that anatomic alignment, staying away from the growth plates, and you know, just that type of injury that you can see even in kids, and kids heal relatively quickly, which is nice, and they usually have a good outcome. Again, something like this, you're expecting 6 to 8 weeks out of work because of this is, you know, an area that you're walking on, obviously at all times. Forefoot fractures, here's another one that we'll talk about that I just saw a few weeks ago. The forefoot, you're gonna see 50% is in the hallux. Hallux is your great toe, and that first metatarsal is the base of the great toe. This is the most common area, and then you'll get the fifth ray, which is the little toe, the long bone with that, and less percentage of those lesser digits because you're pushing off of the great toe, propulsing. That's when you're getting that most of the injury to that great toe. So here's a patient I had just a few weeks ago, was seen after dropping, I think, a refrigerator onto his foot. He went to the emergency department, and I'll show you that he has this avulsion fracture right here. You'll see on the next slide. He went to the emergency department on the left. It went straight through the nail plate. They put him on a short-term dose of antibiotics. They put a single little suture there. It's just kind of cute, that little suture there for that large laceration, and sent him on his way. So this is when I saw him in the office. So quality of care is you have to remove the nail bed or the nail plate anytime you have these. These are considered open fractures. You can see if it went through a nail, then it is deep, obviously. So toenails are dirty. You have to remove it. We remove the toenail completely with the aseptic technique. And then once you inspect the nail bed, make sure there's no exposed bone. Make sure that he's not at risk for developing osteomyelitis or a deep bone infection. Then you clean it out and you can repair the nail bed then, and you can repair that laceration once we debride those margins. Because again, this is something that if this isn't treated seriously and isn't treated efficiently, this can lead to a very bad infection. Again, luckily this is a younger male patient that has a better prognosis for healing. But again, that can lead to osteomyelitis, which is a bone infection where you will either need 6 weeks of IV antibiotics or amputation, surgical debridement. So these can be very serious when you have these open fractures and they're not treated appropriately. It may be an emergency department that isn't seeing these every day like we are. So your forefoot fractures and treatment, external fixation, internal fixation, conservative therapy, just for your general knowledge, if you ever hear Jones fracture, that's when you are going to know that that patient 90% of the time will need surgery. Jones fracture is through this diaphyseal portion of the bone where you can see in the red circle, it has poor blood flow, and that's always this fifth metatarsal, and it needs stable fixation. If it doesn't get stable fixation with its poor blood flow, with some of these patients that they smoke, high blood pressure, high cholesterol, diabetes, this is going to be a non-union. It's not going to heal, and you're going to have someone that has long-term issues associated with this. These are some patients that I had that were healed conservatively. These are at the base of the fifth metatarsal. These are not considered Jones fractures. They're more at the base. These have a better blood supply, metaphyseal region. You can see these healed relatively uneventful. You can't always judge the x-ray. It looks here that there are some areas that are not completely fused, but clinically the patient discharged after 6 to 8 weeks, no pain, because again, it is a well-vascularized area. Here's one that I had with the Jones fracture again. You can see it's more the distal metatarsal. It needs that screw for fixation, stabilization. And again, after about 8 to 10 weeks, that patient then was able to return to work. Here's one of the distal metatarsal, far distal, not considered a Jones fracture. And this is one that if you would look at the x-ray on the left, you would say, wow, that needs surgery 100%. It doesn't. This one is one that we treated conservatively. This patient, again, maybe it takes a little bit longer to return to full activity because you are trying to prevent too much overambulation. But again, this is a good a portion of vascularity, and these heal relatively uneventful. You can see on the right, it's a little bit deformed, but that's fine. She has no issues. She's back to activity as well. But again, all you had to do is move this fracture a little bit more proximal to the mid shaft, and that's not going to heal very well. So getting into some of the direct injuries that we were talking about, impact, and this is when the foot is flexed, and that causes a lot of these injuries, whether they're contusions or a large object dropped on it, the pallet jack that we talked about. These you won't see as often. These are compartment syndromes. This is when there is a large crush injury, there's going to be multiple fractures, the patient's going to need to go to the emergency department and they need a fasciotomy. And that's where you're decreasing the compartment pressure so that the muscles and the tendons and the blood supply is not dying the nerves, because there's so much pressure. It's like a water balloon, just continuously puffing up under the skin, and it kind of kills everything around it. So that's why these have to be decompressed. Again, fortunately, we don't see these often, but when we do, these are sent to the emergency department and they should be handled there promptly. Our puncture wounds, we do see these a lot, whether there's screws, nails, whatever it is, anything out in the field, that they will cause a lot of injury because they go through a dirty shoe, and then that dirty puncture wound goes into the skin. That's why they need, again, direct presentation to an emergency department, tetanus, antibiotics, possible debridement, possible surgery, and removal of that foreign body. The heel, we see a lot of injuries as well. These are people coming off of ladders or jumping off of trucks and whatnot. That's when they will have the traumatic injuries, the calcaneus fractures. That's your heel fracture. That also will need surgical treatment the majority of the times. And then we'll talk about some of the non-emergent heel issues that do not require any type of fixation. So again, back to the ankle real quick. Number one most common site of industrial trauma. Again, people are rolling their ankle. They're not all wearing high ankle boots. And we see this most often. Just to get into a little bit of the anatomy, that's that ligament right there that you can see is torn. That is the most commonly torn ligament in the ankle, that ATFL tendon or ligament, and that is what is most commonly is injured in these rolling ankle injuries. Again, more anatomy, just the medial malleolus, lateral malleolus, that's the inside and outside of your ankle. And if there's displacement, obviously they're going to need surgical attention. Just a little bit more getting into types of different professions, and like we were saying, falling off of ladders and requiring different types of treatment modalities. One thing that I should mention, that with these heel fractures, that should always be a concern and always be examined by medical personnel, is that if you have a fracture of the calcaneus, you have an increased chance of fracturing your lumbar spine. Because of that direct axial loading onto the weight-bearing surface, you may fracture the heel, and then you may also compress that spine. So it's always good to get a lower back workup, whether it's the radiographs, or have a provider that also makes sure that there is no issues with the lower back at that time. You don't want the patient coming back months later and saying, well, I have this lower back pain, I wasn't evaluated for this, and now you're trying to determine whether, again, it was work-related or not. So industrial shoe wear, what we do, or obviously what the workplace does to prevent some of these injuries and prevents these patients from seeing us, is the safety shoe wear, these standards of care. You can see your standard work boot, and then you can see some of the things that we use for protection. So here's the toe cap boots, and that provides a steel toe liner for the shoe. And then this brace down here, the TACO brace, this is one thing that we give to some of our workers' compensation patients that need to return to the workplace and can't wear the cam boot, the walking boot. They can get this TACO brace here, the black brace, and it allows it to go over the shoe, and it basically turns into a cam boot, a walking boot. So that is a good orthotic that we have been utilizing. So real quick, just Achilles tendon injuries. This is something that we see mostly in patients, 3rd to 5th decades, or the 30 to 50-year-olds. Fortunately, it's more the weekend warriors and less of the workers' compensation, workers' comp patients, because just the type of activity. Again, just getting into it real quickly, some of the presentation that we'll see as providers is the difference in the ruptured side versus the normal side, the tension in the area. So not as common in the workplace, because there aren't, they should not be doing as much of the strenuous work, which is fortunate, but they will hear that snap, that pop, the acute pain. They won't be able to ambulate. There will be a significant swelling. And these are some of the tests that we do. Thompson test, we squeeze it just to see if that tendon is intact. If it's intact, then your toes are going to flex. If they're not, then it's just going to lay limp. What we do for further evaluation, in addition to the Thompson test, because there are other tendons there that can compensate for that, so it's not always 100% sensitive. So we use the MRI, the ultrasound, even some x-rays can show whether there is an Achilles rupture. And again, just getting into some of the repairs that we do, if it needs surgical repair based on the extent or the rupture, the gap in the rupture. Plantar fasciitis, this is one of the things I was talking about that's kind of hard to discern between whether it's acute or chronic, but we do have patients that come in, they say that they've been walking on hard surface in warehouse or on concrete for 12 hours a day. They have heel pain and they say, I think it's work related. And then we have to evaluate and say, is this work related or is this a chronic standing issue that you've always had? So you can see here the heel spur, that is telling us that this is a chronic issue. The heel spur is not what actually causes pain. It's the tendon that is, or the ligament that is pulling on the heel spur that is pulling away from the bone and creating the heel spur. So again, we know this is a chronic issue, lack of stretching, overactivity without being properly stretched, and just being more sedentary than the patient should be. So again, just some of the treatments that we do for it. So very rarely, fortunately, is this surgically indicated, which is the good news. If it is determined to be a work-related injury, we can treat this conservatively I'd say 99% of the time. So the stress fractures, these are again the ones that are kind of hard to distinguish whether these are truly a workers' compensation case or not, because this is it's not an acute injury, this is just repetitive trauma to an area. We see these in the midfoot, the heel, and the forefoot. We basically see them all over the foot. Again, you can see on the right, this is a patient that I had significant pain, thought it was plantar fasciitis. It was recalcitrant. We couldn't get rid of the pain. And what it ended up being was a stress fracture. You can see all this white. Bone should be black on this MRI, and it's white. It's just edema, too much swelling in the bone. It's almost a repetitive bone contusion. So those patients, we have to have them stop activity. They're either non-weight bearing or in the protected cam boot until that inflammation can kind of calm down. Again, it is a fracture. It's just not a complete fracture through both cortices of the bone, but we just have to prevent that from being a complete fracture. I also threw in some of these pictures since we're getting close to Halloween, so we'll throw a few of these as well. But again, the tibia, the fibula, those are the ankle bones, and the metatarsals, we will see fractures in all of them. A lot of times it will be females. They are getting to that age where they're starting to get osteoporosis, osteopenia, and those long bones will fracture when there's a deforming force in that repetitive trauma. So the x-rays, the one unfortunate thing about x-rays is that you don't see a stress fracture until about 14 days. So we might have this patient, you get x-rays, it's negative, but that doesn't mean there isn't a stress fracture. You don't see findings until you see the bone callus, which is almost a halo of bone that shows up several weeks later. So that's why sometimes we have to order the MRI or a CAT scan. But again, we usually treat these conservatively, and you can just get those follow-up radiographs after 2 to 3 weeks to see if that's in fact what it was. So our general physical exam, why again, it is important to see a specialized provider so you can rule these out. So these patients aren't going to emergency department telling them it's nothing, and then you find out it is a stress fracture because again, nothing was found on that physical exam. We use a tuning fork, which is what you probably remember when they do the auditory test, like that Rhine test where they hit the tuning fork and put it up to your ear when you were younger. We do this for the bones as well. It'll send chattering vibration through the bones, and you'll be able to really determine if there is a stress fracture that will be significantly painful. The patients will have a markedly swollen foot. That's one of the signs of the stress fracture. We'll see in there. It's very swollen, x-rays are negative, and then this vibration test is positive. We know that it's going to be a stress fracture. Again, excessive ambulation, concrete, poor shoe wear, these are all things that can lead to it. It's now that gray area whether this was suffered from the workplace or this is because of the patient was on a hiking trip over the weekend wearing sandals, and that's what caused it. So this is something why workplaces have to stress wearing the correct shoe wear, correct padding in their shoes, so that they can rule out that this was the cause of some of these injuries. And you can see some of this little halo forming around that bone in that white area, that little thickened area of the cortice, that we know that stress fracture did occur there. Some of the causes, obviously, like I was saying, weekend activities at home, walking barefoot, hard surfaces. So, hopefully nothing that's happening at work. Fifth metatarsal fractures, we already talked about that. That would require fixation or complete non-weight bearing because of that poor vascularity there. There's another patient I had. So you can see, we kind of joked about, this is the positive mulch sign on the back of the heel. You can see there's mulch in the cast. The cast is worn away. The patient obviously was weight bearing on the cast despite our recommendations not to. So right there, we already know that the patient's not being compliant. But that's why a lot of providers have gotten away from the casts, because sometimes the patients think they can just walk on them. Stress fractures, again, these are something that we will see more on the MRIs. You'll see the bone edema, that white area in the bone that looks like there's a lot of swelling. You may see a complete fracture, and these can lead to a complete fracture if not careful. So these are patients we have to make non-weight bearing or partial weight bearing or protected weight bearing crutches, whether it's the rolling knee scooter. But a lot of times these patients can return to work. We can put them in sit down duty, light duty, limited to a specific number of hours for ambulation per day. So that's good that we can always just modify that. Again, just more kind of the anatomy behind it and some of the weight bearing treatment. But these patients are usually in the cam walker. If they don't need surgery, they're going to be in that, whether it's with the crutches, the rolling knee scooter that we use a lot, as long as it does not progress to a fracture. If it progresses to a fracture, then yes, you will need that surgery. So this is the patient that was working at FedEx. I believe you can see the rolling knee scooter in the background on the left. They came in and they said that this was injured at work, and they had been working and they're forced to walk at work. And but what you don't know initially, this patient has underlying diabetes, a hemoglobin A1C of 15, peripheral neuropathy, and this is all from poorly controlled diabetes. You can see the ulceration on the outside from wearing a cam boot. They were placed in a cam boot by a provider or an emergency department, went to an emergency department, told them that it was just a fracture. So again, they think it's a work-related issue, but again, this is what we call diabetic Charcot-neuroarthropathy. It's a Charcot event where the bone just starts refracturing. The patient has no feeling in their leg. They're walking on fractured ankle, fractured bones, and it leads to a lot of issues when these patients are walking around. They're diabetic and not properly controlled, with their diabetes. Tibial stress fracture. This is again what we see a lot in females. And it's right at that area. We know that that is a stress fracture when we see that that's the area of pain. There's swelling, and it's usually again from more of that repetitive activity. And we will put them in a cam boot 4 to 6 weeks, and then they can gradually return to activity. Sometimes they just need an ankle brace, and that's a good thing. You can put an ankle brace inside a work boot or a sneaker. Again, further treatment for some of these patients, because these women are in their 30s or 40s, a lot of them don't know about it leading into osteopenia and the old, what people used to say, female fertile and whatnot. Those are the hallmark signs of these stress fractures and DVTs and whatnot. So what we do recommend, the vitamin D supplementation, calcium, all of those, so that these women of that age range are strengthening their bones and are not having multiple fractures. So some of the midfoot sprains we talked about, very common in the workplace. The tarsal metatarsal sprains, that's just your midfoot. Again, this is just general swelling. We have to have an early diagnosis for these, determine if it's a stress fracture, a sprain. and see if they need any immobilization. Again, just more anatomy of the midfoot where we see these injuries. The mechanism of injury, which I've seen most commonly, are patients stepping off curbs. So they're walking out to the work truck, they're stepping off of a curb, their foot's plantar flex, you can see right here, and all that axial loading of some of these people, they may be a little bit overweight, they may have osteopenia, that this loading goes down and that bone cracks, fractures, and we see that pretty often. This is a patient I had that then required surgery because they had a second metatarsal fracture, second metatarsal fracture, third metatarsal, a dislocation of the first, and this Lisfranc joint that we talked about, that this ligament, once this ruptures, this ligament, the whole foot is stabilized. So then that also required surgical attention. A lot of these are missed because they are subtle injuries. Sometimes you won't see them on x-rays right away. So it's all based on physical exam. That's why we go through everything and trying to have them stand on one limb, or the piano key test where you're pressing down on the second toe to see if you get radiating pain at the base, whether we use the tuning fork and stress film. Sometimes we will have to stress the foot during the x-ray or compare the other side. So sometimes we'll take x-rays of both sides to kind of compare. So you can see right here, getting weight-bearing radiographs bilaterally to kind of compare, and then you'll be able to see if there is that fracture of that area. In that patient, you saw that there was a FLECK sign. That's usually the gapping, and that is usually that midfoot fracture that you might not see unless you were to get weight-bearing films to see if it's a normal anatomic variant or not. So imaging for these, we usually need a CAT scan if there is determined to be a fracture, and then we know that you're going to need surgical planning. We're usually ruling out whether it is significant fracturing there, comminution, joint involvement. MRI is usually when we are kind of iffy on whether there is that midfoot injury, but we know that it's probably more ligamentous than anything. So again, treatment is conservative. If there's not much displacement, we're going to put them in non-weight bearing. And if that's the MRI determines there's maybe a Lisfranc sprain or a Lisfranc rupture without gapping and destabilization, then maybe we'll just put them in a cast, non-weight bearing, 6 to 8 weeks, sometimes 10 weeks for some of these patients, again, based on maybe comorbidities, obesity, sex of the patient obviously determines it as well with the osteopenia and whatnot. Surgical, then this is kind of another one of those areas that we have to determine whether it's better to just repair the fractures or actually fuse the joints itself because of all the damage that was done for the ligaments and the bone itself. So you can see here's a patient that actually underwent fusion because usually there's so much damage in the joints itself that there are better functional outcomes when you fuse the joints so that you don't have to take out the hardware later. So again, for some of the nursing case managers that are here with us today, they might say, well, we got the report, the x-ray said that there was just a fracture at the base of the second metatarsal. It shouldn't be that bad of an injury. Then we get a CAT scan and you see that all of these bases are actually destroyed. You just can't see it real well on an x-ray because you're seeing a one-dimensional image. And then it's better to fuse a patient rather than getting post-traumatic arthritis and then saying that this is a long-standing issue from this injury. So again, here's a patient that we had, and if you were to look initially, you'd say, well, it doesn't look that bad. You can see the Lisfranc injury that we talked about. There's a little bit of gapping, the FLECK, and then this metatarsal shortened. So what happened was when we got the CAT scan, there was actually a fracture at the neck of the second metatarsal because that should be a little bit longer. The base was fractured. There's a dislocation, and you can see this round bone here in the front of the foot, the sesamoid, that is actually kind of destroyed. You can see that's in about 8 different pieces. So this was a large impact injury that, again, on initial radiographs doesn't look like it's terrible, but then you get the CAT scan and you see just how bad it is, and then we have to fuse the joints. You can see the fusion that was performed here, and this patient's doing great actually. Her most significant pain now is a sesamoid fracture because unfortunately you rarely can fix these little bones, the little bones in the ball of the foot, where we say the ball of your foot. they unfortunately are not repaired very well. So of all the fractures she had in her foot, the little sesamoid in the front of her foot, unfortunately, is causing her the most significant issues moving forward. And then when you hear that a patient needs either the primary fusion or just the open reduction with internal fixation, there are multiple studies that show the outcomes of these patients, and they usually do better with the primary fusion if there's a lot of that bone fracturing comminution. Just because they have a quicker recovery, the bones are fused, you don't have to worry about the plates breaking, the screws breaking, because the bone-on-bone contact is better, and they have better function than the patients that you have to worry about taking the plates out and having more of that post-traumatic arthritis because the destroyed joint is still there. Moving on to that lateral ankle sprains, because that's what we see the most. Obviously, 25% of all musculoskeletal injuries, and 23,000 patients a day in the US are diagnosed, so that's a lot. These are just your risk factors for people that have the ankle sprains that we kind of see on both sides of the foot and ankle. So stepping off the ladder, rolling the ankle on the sidewalk, again, we see that a lot. We kind of talked about that earlier, that ATFL ligament there is the one that's most commonly torn. And this is all of our physical exam. It needs to be a very well problem-focused exam. We'll see the ecchymosis or the bruising, the edema, the tenderness. Sometimes they have a history of recurrent ankle sprains, so they're not wearing adequate shoe wear, they're not wearing adequate ankle braces, they haven't been to rehab, so they have weak ligaments. An anterior drawer test where we kind of pull on the front of the foot to determine if there is truly a rupture of the ligament. And just different tests that these, again, a specialized provider will perform that you're not going to get in an emergency department, unfortunately, because it's not something they see every day. So again, these are just some of the tests that we do. The ATFL that we talked about is the most common. And then just your grades. Your grades, if it's a grade 1 sprain, then we know that you're not going to need surgical repair. Grade 2 is a partial rupture, which we would see on MRI, and grade 3, complete rupture. These are what we are ordering MRIs for to determine if this patient is going to have ligamentous laxity in the future, if they're going to have recurrent ankle sprains, or need surgical intervention down the road because now they have an impaired ankle joint that has just a scarred tendon rather than a scarred ligament instead of an intact ligament. So again, just some of our treatment modality, our imaging modalities and what we do for them. So the grade 1s, we are just the protective immobilization or protective weight bearing, and then your RICE therapy, rest, ice compression, elevation, return to activity. These are some of those patients that, again, you might see that they want to come back to work the next day. We're given an ankle brace and they're back in just 3 or 4 days. As long as they are doing their home physical therapy, and we provide that. So every patient that gets an ankle sprain, I give them the red stretch bands, those TheraBands. They're doing seated range of motion exercises after the swelling goes down, strengthening those ligaments so that you're not getting those recurrent ligaments. Here's just a website that anyone can go to in the future. Just kind of talks about more foot and ankle pathology in the workplace. This is actually a lawyer's website, so it's actually telling the patients, what to look for and the average cost of, foot and ankle injuries and what they're quote unquote worth. So again, physical therapy, we haven't talked too much about it, but it is a great modality to use. We need to get the patients earlier return to their activity. They can do it in their protected ankle brace. We can send them in their cam boot, the cam walker. They can do gait training, and it really increases the outcome. I'd say the largest barrier to this is patients finding time for it. They say that they work from 8 in the morning till 8 at night, and they just don't have time for physical therapy. But luckily, that's why a lot of physical therapy offices now are open earlier in the morning and later at night. High syndesmotic sprains, we won't talk about this too much because these aren't seen often, but again, some of the tests that we do, your specialized provider that will kind of show you how to identify that. So follow-up care for a lot of these injuries, I see my patients after the initial sprain injury. I see them 1 to 2 weeks later, usually 2 weeks, just to kind of see how they're doing with the protective weight bearing. If they need to progress to that ankle stabilizing brace, or if they're ready for physical therapy once they're doing those home stretching exercises. These are some of the more, you know, everyday podiatry, I guess you could say, foot problems that we see. Some of these work boots, they're blisters, they're separation of the skin. Some of these, you know, construction workers are outside in wet conditions. They're soaked shoes from the rain, and they're kind of developing these blisters. So sometimes we have to drain these, give them a special cream called silver sulfidizine cream that helps really speed up the repair process of these. But again, this is why we need to stress that the patients, they're wearing the right protective shoe wear at work. More kind of iffy areas, gray areas. Sometimes you have patients come in with an ingrown toenail and they'll say, yeah, well, I dropped something on it at work and that's what caused it. Again, whether it really is 100% related to work, if they had the contusion to the area, then, you know, then it probably did contribute to it. But a lot of times this is hereditary or from shoe wear. As well as the patients that have the subungual hematoma, where just a little blood accumulation under the nail from jamming into their work boots. Turf toe, again, more of a sports injury, but it still can happen. Patients that are propulsing and pushing off, lifting and carrying some of their objects in the workplace. So the cost of injury, there was a study that they said the average foot and ankle injury is worth about $10,000. What not a lot of us want to hear, but the patients want to hear, or I'm sorry, the lawyers want to hear, or they relate to the patients that they need to be evaluated because of this. $23,000 if it's a foot and ankle injury. Again, a pretty substantial amount when you're talking about MRIs, x-rays, possible surgical intervention, days off of work, lost wages, all of that stuff. So it is something that we need to treat seriously to prevent this accumulating cost for the patient, the workplace, you know, for all parties involved. So in closing, just before I get into a few of the cases that I have done, timing with the treatment with a specialist is key. Again, some of those you saw that they went to emergency department, they say follow up with a foot and ankle or provider in 1 to 2 weeks, or they don't go to a concentra on time, and they miss a lot. Not a lot, but they can miss some of these injuries. I had a patient where they said that their leg got ran over by a pallet jack. They went to emergency department. They took ankle films, they took lower leg films, they didn't take metatarsal films, the foot films in the front of the foot. She came to my office 10 days later after injury, still swollen, no surgical shoe, and she had 3 metatarsal fractures. So we actually just did surgery on her on Tuesday. And this was, again, something that was missed in an emergency department when there were multiple radiographs taken. Again, sometimes you don't know how they miss it, but they do this, you know, especially with COVID. They're pushing people in and out of these emergency departments quickly, so things can be missed. Physical therapy, great modality, increases functional outcome scores. There's the work hardening, the work conditioning, functional capacity exams, everything that can get some of these patients that are, they're lingering patients that you can tell they don't want to go back to work, and we need to get them to go back to work. So we say you have to do this work hardening or the functional capacity exam to determine what exactly you can or cannot do. Because sometimes you can't tell in the office. Sometimes the patient may be pretty good at expressing that this is a terrible injury and it's debilitating, and you really can't tell them otherwise, despite all of, you know, your imaging modalities being negative. You know, sometimes it's just hard to determine what they can or can't you know, do in their daily job, because I don't know what their true daily activity is for a 12-hour day and how strenuous it is on their feet, or you know, how many pounds they are pushing or carrying. So again, this is the patient that I had. We're going to watch this video real quick, as long as no one's squeamish. Sorry, you might want to close your eyes. But this is the patient I had, and this was a pallet jack injury. He's on the operating table prior to doing surgery, open fracture. You can see he does have some motion to his front of the foot, the lateral foot. He almost did not have any motion. The nerves were severed, the arteries, the tendons, and you can see he had almost these clean metatarsal fractures, which is pretty nice for repair wise. But again, it is a very serious injury that needs operative, emergent surgery. So this is what you can see after we kind of debride the tissue, clean up some of the dead tissue. You can see we've repaired the tendons. We've what's called anastomose. You repaired the good tendon the bad tendons to the good tendons to try to get them to function together. We pin those metatarsal fractures. You put a drain in the foot to prevent fluid accumulation in all the blood. And you're hoping that these lateral 3 toes are going to survive because the blood flow is obviously impaired. So you can see we pin the first one, you pin the second one, you pin the third one. And again, you can get them pretty well approximated, which is good. Everything looks almost nearly anatomic. I mean, that's almost as perfect as we can kind of expect for a patient. And then this, I mean, again, it looks almost as though, the fracture never occurred, which is as well of an outcome as you can expect immediately, with the exception of hoping that the toe survive. So then this is a few weeks out. You can see because of the poor blood flow, some of the tissue dies. As a patient, we got into hyperbarics then, the hyperbaric oxygen treatment to increase the blood flow. Fortunately, the patient is relatively young, not a smoker, not diabetic, does not have sensation of the 4th or 5th toe, cannot feel them. He still has some range of motion, which is good. And then you can see, then you have to take them back to another debridement. So you have to take them back to the operating room because that is dead tissue that can create infection. And there's bone under there. You don't want that to get infected. So we cut out all that black tissue. We put a wound matrix substitute on there. And then you hope that, again, that starts to revascularize. Again, unfortunately, you get serial radiographs. You want to make sure that this patient's progressing. You can see that these bones are not as good of quality as you expect because of the vascular issue. Despite hyperbarics, this 4th metatarsal is kind of washed out. It's kind of darker than the surrounding white bone around it, probably because of the lack of blood flow. And then when he started walking on it, and this is even 2 months out, or I'm sorry, maybe 10 weeks out, that he is still getting some fracturing of there because the bones are weak, because he was on weight bearing for a while. Again, we're still actively treating this patient, doing well, but again, this is something that can happen in follow-up of these new fractures, unfortunately. This is a patient we had that kind of stepped through a glass pane, went to the emergency department. Emergency department did not get an MRI. They thought it was just a laceration. They did a few sutures in it. The patient came to my office, said they rolled their ankle once or twice. It's because the peroneal tendon was lacerated. The glass cut through the tendon. They couldn't see it, obviously, just on the x-rays you get because it's soft tissue. And the patient now had no eversion strength of the foot, rolls the foot repetitively, had multiple injuries, and fortunately we got an MRI, without too much retraction of the tendon. So you can see then we repaired the tendon. This is the one that we use a cadaver allograft. So we use a cadaveric tissue because there was a gap. This is the cadaver tissue with the forceps in my left fingers. And we kind of put them back to, we pull them as close as we can, use a cadaver tissue, and then we will suture these together so that they function as one. And again, this was a younger patient, returned to activity just after, I'd say maybe 6 weeks. She was walking pretty well at that 4 to 6 week mark. Again, fortunately, because she was, 21 or 22 years old. Another one that we had where it was radiographs. If you look at the top left, you see an x-ray and you say, yeah, that patient's fine. There's no injury. You can't really see anything on x-ray. They have pain in the ankle and you're just not sure what the injury could be because everything looks okay. We make them protective weight bearing in a boot or non-weight bearing if they can't tolerate it. You see them back in 2 weeks, you get follow-up radiographs. The patient's still having significant pain on range of motion exam. That's when we need our x-ray, or I'm sorry, an MRI or CT, and you see that there is a fracture there. So there is a non-displaced fracture that unfortunately is causing residual pain. These do require surgery because the talus does not have great blood flow. So that ankle bone in the middle does not have great blood flow. Unfortunately, it does need surgery. Even though it's a little bit of a delayed surgery, it still needs that surgical attention. And then I actually got a note from the patient the other day saying just how great they're doing and how happy they are that they had the surgery. Because again, this was missed initially by initial evaluation of a provider. So that's about everything. We kind of sped through that, talked a little fast. This is also a patient I had in residency. We'll kind of, so you don't have to look at that, but you know, definitely something that we have to be concerned with. Take all the proper precautions as the workplace provider, I'm sorry, the workplace managers, superintendents, and owners of these businesses to make sure that this does not happen in the workplace. And then if it does, that you have adequate follow-up. So you know that these patients are getting proper care. They're not getting excessive treatment. They're not getting underdiagnosed, so that everything, again, is managed efficiently, cost effectively, and what's, of course, in the best interest of the patient overall. Okay,
great. Thank you, Dr. Falci. That was spectacular. Let me remind our audience that the Q&A button is open if you want to throw a question in there. But as people are kind of thinking about that, let me hit you with one that I'm curious about. If you what have you found to be the keys that you need to consider as the physician when you see a patient with an injury? Any big keys you want to talk to us about?
Yeah, so the keys that I kind of go through with every patient is obviously what they're feeling subjectively, and then what you're seeing clinically and objectively. So the patient comes in, they have foot pain. You have to palpate all areas. I always ask what they were wearing at the time of injury, what they were wearing, what motion their foot or ankle was in, because that is a very large component of your exam. There's patients where you think that they had just a standard rolled ankle, and then they tell you that their foot was in this position or that position, and you understand that it's not a standard ankle fracture. It's a different mechanism of injury. You might need an MRI for that versus an X-ray, but I always want to make sure I know what they're wearing, the type of injury that was sustained, the type of work they do. I need to understand how many hours a day they're on their feet, and kind of almost their home life as well. Sometimes you need to find out what these patients, how many stairs are in their home. Some of them can't be non-weight bearing. So you just, again, you have to look at the whole picture, start with an X-ray really, and kind of go from there.
Thank you. That it is a whole big picture, isn't it? Let me hit you with a couple quick questions here. Dee asks, can you only identify a fracture to the sesamoid via MRI?
No. So the good thing is about sesamoid fractures, that was noticed on X-ray immediately because the comminution just means the extensive fracturing. Sometimes I will say you are correct in that you might need an MRI. You can have what's called a bipartite sesamoid, where a lot of people have sesamoids that have a natural, it looks like a fracture line through the sesamoid. That's why, another reason why I said you might need films of both sides, of both foot and ankle, to see if it's a normal variant. Sometimes, yes, I agree, you may need an MRI, but a lot of times those sesamoid fractures you'll see right on X-ray. I mean, you know, when you have a little round bone, if you see a little chip off of it, if you see any irregularity of that sesamoid, I mean, you are almost positive that's a fracture, whether a ligament avulsed off of it, or again, if it's fractured. So I'd say I've only had to do an MRI on a sesamoid fracture once, and is because it was from post-traumatic arthritis. It was down the road to determine whether it was a sesamoid fracture or.
So it's definitely a great tool for the practitioner to have.
Yep.
When he or she feels that they need that extra information. Great.
Yep.
There's a question about, do you have a preference for recommending steel-toed boots versus composite-toed boots in a warehouse environment? And if so, why?
I don't know what your thoughts are on this, Dr. Song, and having your history of the workers' compensation patients longer than I have actually, but I don't know. I unfortunately can't answer that question real well. Still too, again, that depends on what type of activity they're doing. Yeah, I don't know.
Yeah, I would agree. I think there are definite advantages and disadvantages to both. And it's one of those things, if one was a clear-cut winner in all environments, we'd only have one. The other would just kind of die off. So thank you.
But steel-toe boots obviously are going to provide more of protection, but it's all based on what the patient's the worker's actually doing in their daily work activity, whether it's really beneficial to have it or not. I mean, that's really carrying things, pallet jacks, that you would really want to stress wearing them to prevent those injuries. I mean, you might be putting steel-toe boots on everyone when, they're just not in that environment where it's really necessary.
Great, thank you. I think that's terrific. Let me, I don't want to run out of time. Let me go to the next slide. I have two important things as we wrap up here. The first one that people are going to want.
Sorry, real quick. There was a follow-up question to the sesamoid one that I wanted to address real quick.
Go ahead, sure.
Conservatively or surgically for the sesamoid fracture. So we always try to treat those conservatively. Initially, we treat them as conservative as we can. If they need surgery, that is usually something that we perform down the road, unfortunately, and that is usually a sesamoid removal. Because again, if those sesamoids, they're such small bones, if they're fractured, if they're not coming back together, they end up just being removed. And we do remove those often. You may have to repair the tendon then, but I always try to treat them conservatively for at least 3 months. And at 90 days, if it's still not healed, then that is when sometimes insurance will allow for a bone stimulator to increase that healing potential. And then after that, then you may need surgery. But very rarely does a sesamoid need immediate surgical repair.
Great, thank you. Okay. Thank you so much, everybody, for hanging in there, especially since I forgot to warn you. We had some exciting slides that I probably should have warned you about. In order to get your CME credit, for some of you like your CME credit, please follow these instructions. You're going to email Melissa Lease. She'll send you the forms that you need. You're going to complete them and just get them back to her, and you'll know that it's complete because we'll email you a certificate back. So also reach out if you have any other questions, concerns, constructive criticism for our first webinar. That would be terrific. And the other thing I need to tell you about is I want you to be on the lookout for more information about our next webinar, the Concussion Continuum. That'll be Dr. Shannon Schultz, and it'll be Wednesday, November 18th from 11 to 12. And we'll get those details out to you. But again, if you have suggestions on how we might make that one different, better, whatever, let us know. All right. But this one's going to be hard to top, I got to say. Great job, Dr. Falci.
Thank you. Appreciate it. Thanks, everyone, for obviously coming and spending an hour with us. And any questions you have, unfortunately, I forgot to put my contact info there, but you can reach out to Melissa Lease. Reach out to me at OSS, Dr. Song. Any questions you guys need, you can contact us directly. But my email is mfauci, F as in Frank, A-L-C-I, not like Dr. Fauci from the CDC, just a little bit different spelling, but mfauci at osshealth.com, or email Melissa now that you have her contact information. She'll get those questions to me and you can contact us at any time. But thank you guys. Thank you, Dr. Song.
Yep, great. Thanks, everybody. Go back to work and have a great weekend. We'll see you next time. Thanks. Bye.
Thanks.